Pulmonary medicine section 2 will talk about the pulmonary function test and occupational lung diseases. So for the sake of the exam, they might provide you with some information regarding pulmonary function test and ask you about the diagnosis. So this is the easy way to look at it. If they talk about the problem with the flow, which is basically the ratio between FEV1 to forced vital capacity, we know that the normal FEV1 is 80%. So look at the flow to see if the patient has obstructive disease or not. If there is obstructive disease and the FEV1 is less than 80%, usually provide you with 70%, something like obvious that it is low. And now you have obstructive lung disease. The first thing that you do is start with the bronchodilator challenge. If they tell you that the FEV1 has improved, it means that the patient has asthma. If there is no improvement, check the DLCO, which is diffuse capacity of lungs for carbon monoxide. If it is low, this is emphysema. If it is normal or increased, it is asthma. Most of the time on our exam, you are going to go this way. Low FEV1, meaning obstructive lung disease. Tell you you started the patient on bronchodilator and there is significant improvement. So that's very obvious that this is asthma. And if there is no improvement and the DLCO is low, most probably they talk about the emphysema.
So if you have a patient who's a high risk for COPD and the test asks you what's the best next diagnostic step, are you going to do spirometry or are you going to do PFTs? Because I don't think you can do DLCO.
Oh, no, it's not spirometry. I mean, spirometry is the very first step, and it's going to tell you if the patient has obstructive lung disease or not. But to get the DLCO, you have to do the whole comprehensive pulmonary function test. The other thing that I'm going to talk about it in a minute is this. So that's the scenario that I want you to look at it here with the use of bronchodilator. Okay. The next, look at the volumes. By the way, as you mentioned, the spirometry will not going to determine the total lung capacity. That will not going to be determined in the office. It has to be done with the pulmonary function test. And they give you the total lung capacity, most probably the forced vital capacity as well. But look at the total lung capacity. If it is low, what does it mean? It means that the patient has restrictive lung disease, and check the DLCO. If it is low, that's interstitial lung disease. If it is normal, it is not a lung problem. The patient has restriction in the lung movement, restrictive lung disease, but it is not due to lung disease. It is due to something outside of the lungs, like severe obesity, significant morbid obesity, or the patient who has a kyphosis or scoliosis. So the lung is 100% innocent. I mean, the lung is completely normal. But the restriction of the lung is due to something outside if the DLCO is normal. Okay? So you cannot tell that the patient has restrictive lung disease without the total lung capacity. So you cannot say this based on spirometry in an outpatient. That will not gonna help you to determine total lung. To determine the total lung capacity, and this is the only way that you say that the patient has a restrictive lung disease. Okay. Here in this situation with restrictive lung disease, the flow most probably is going to be either normal or even supernormal because of the lung condition, which is a restrictive kind of situation. Here is some of the pattern. When you see a normal pulmonary function test with only increased diffusing capacity for carbon monoxide or DLCO, think of polycythemia or pulmonary hemorrhage, ventricular septal defect with left to right shunt, because the shunt will increase the volume of the blood in the pulmonary capillary, will increase the DLCO. Okay? So patient has the only problem that they give it to you on the exam with pulmonary function test is actually increased DLCO, not decreased. Think of something that's going to push the blood volume to the pulmonary capillaries significantly, such as polycythemia or patients with left to right shunt with congenital heart disease. The low volume of the lung or low lung volume with normal DLCO, think of extra pulmonary cause such as obesity or severe kyphosis. That's what I talked about it before. DLCO is normal. Lung volume is low, like restrictive lung disease, which is not due to lung problem. It is extra pulmonary problem. For the flow volume loop pattern, they like to put this on the exam. So I want you to follow me for these conditions. Here is the normal flow volume loop. This is the dotted one is the normal one. However, if the flattening of both curve A, so like here in the curve A, we have the expiratory flattening, and by the way, this is inspiratory, this is expiratory part of the flow volume loop. So if both of them are flattened, like the inspiratory and expiratory, consider pathologic process involving the trachea, and for the sake of the exam, most probably is going to be the patient who has been on the vent for a long time, causing tracheal stenosis, or if the patient has very large goiter compression, causing compression of the trachea. That's the two scenarios that you will see this pattern, which is flattening of the inspiratory and expiratory part of the curve. The flattening of the lower curve, which is the inspiratory, here on B, indicates variable extrathoracic disorder. Look at this. You guys remember when we talked about the paradoxical vocal cord motion? I told you that the patient will have, during inspiration, adduction of the vocal cord rather than abduction. So that's the one that you will see, flattening of the inspiratory part of the loop. Okay? And for definitive diagnosis, when you see this shape of the flow volume loop, send the patient for laryngoscopy, and the ENT is going to tell you that this patient has paradoxical vocal cord motion. The third one is flattening of the upper curve, which is expiratory. In curve C, means a variable intrathoracic disorder like intrathoracic tracheomalacia or tracheal tumor involving only the intrathoracic part of the trachea. Okay, so that's the three patterns that we need to remember, because that could be a good question on the exam. Moving on, interstitial lung disease, and all of them are associated with restrictive lung disease. Interstitial lung disease associated with restrictive lung disease on the pulmonary function test. Okay, and the interstitial lung disease is the best way to look at it, occupational and non-occupational. And as I mentioned, most of or all the interstitial lung disease are associated with restrictive lung pattern on pulmonary function test, and most probably you will see like interstitial increasing marking of the interstitium, and if you got a CAT scan, you will see the same like diffuse kind of interstitial marking as well. The history, they have to tell you that the patient has dyspnea. Dyspnea is very important in the history of patient with interstitial lung disease. You got a chest X-ray, as we mentioned, diffuse interstitial infiltrate. And remember that radiologic picture of the patients is not correlated with the severity, meaning you see a patient with chest X-ray that's terrible with significant interstitial marking, and the patient clinically doing okay, and vice versa. So that's not like correlate to the patient condition. High resolution CAT scan, 1 to 2 milli cuts is very useful. And again, pulmonary function test is going to help. What are you going to see with pulmonary function test? It's going to be restrictive lung disease. How are you going to say that the patient has restrictive lung disease? What is the number that you need to look at it? Total lung capacity. I'm repeating this because it's important. Spirometry will never tell you that the patient has restrictive lung disease. You have to have total lung capacity, and it's reduced. And when the total lung capacity is reduced, you can say that the patient has restrictive lung disease. So let me give you this hint. Chronic interstitial lung disease has restrictive pattern. So total lung capacity, forced vital capacity, residual volume, and DLCO will be reduced. But the most important factor, meaning you cannot stand in the court and raise your right hand and tell them this patient has restrictive lung disease without total lung capacity. If you have this and it's reduced, you can say, hey, I can document that this patient has restrictive lung disease. However, the other factors most probably is going to be diminished as well. You remember when we talked about the flow, the ratio is going to be either normal or supernormal. Sometimes it is even more than normal in restrictive lung disease. This is hint for our exam. Some of the patients with sarcoidosis, lymphangioliomatosis, or eosinophilic granulomatosis might have both obstructive and restrictive lung disease. So the main problem that they have is restrictive lung disease, but some of them might have obstructive lung disease as well. How are you going to see this on the exam? They will tell you the patient has total lung capacity which is reduced, and you look at the ratio, and the ratio is reduced as well. Now you can say, oh, are you talking about sarcoidosis, lymphangioliomatosis, or eosinophilic or Langerhans cell granulomatosis? So the most probably is going to be mixed between obstructive and restrictive. The radiologic clues for interstitial lung disease for our exam and for your practice, the asbestosis should be in the lower lung field. Why? Because the asbestos is very heavy, and it's going to drop down in the bottom of the lungs. The other condition that has lower lung field fibrosis and marking is idiopathic pulmonary fibrosis. Both of them are in the lower lung field. Silicosis, hilar eggshell calcification. Sarcoidosis, bilateral hilar predominance of the enlarged lymph nodes. Lymphangioliomatosis, pneumothorax. You guys remember when we talked about spontaneous pneumothorax? So that's spontaneous pneumothorax in premenopausal woman. That's a hint for the radiologic appearance on interstitial lung disease. I'm going to start with the occupational interstitial lung diseases, and we have only one organic dust that we need to know. If you look at the pulmonology text or the pathology text, you would see, believe me, more than I'm telling you the truth. You might see like 70 to 80 subtypes of interstitial lung disease, but we are not responsible for all of them. These are the interstitial lung disease that we need to know. And the only organic dust that we need to know is the cotton dust or causing biocinosis. We have the inorganic, we have this four. We have the silicosis, coal worker, and the berylliosis and asbestosis as well. Okay, there is specific condition which we put it under occupational, which we call it hypersensitivity pneumonitis, and I'm going to tell you how to diagnose each one in an easy way. So for silicosis, it's exposure to silica, And the question on the exam most probably is going to be very obvious that there is the eggshell. This is one of my patients with the eggshell kind of calcification of the lymph nodes and the interstitial markings as well. History is helpful. However, the question will be this on the exam. They will tell you up front that the patient has silicosis because he has exposure to during his work for silica. And they tell you he's in the emergency room with fever. What are you going to do? What is going to come to your mind? The first thing that will come to your mind is this, TB. So these patients are susceptible to get a TB infection. So what are you going to do? Check the PPD test. And you don't have to wait for 15 millimeter. Only 10 millimeter is required for the treatment for a patient who has silicosis and he has positive PPD test. Okay? So that's the question on silicosis. This is the occupations that will increase the risk for select any one of this, and they might put it on the exam, and that's the silicosis. The co-worker pneumoconiosis is the patient who is exposed to coal during their work, and they will have what we call it pneumoconiosis. If you see the lung autopsy of one of these patients, it's really black. I mean, I have seen some of these patients with a really black lungs. Okay, so that will be very obvious. What do you mean by Kaplan syndrome? We always put this criteria here: seropositive rheumatoid arthritis, co-worker pneumoconiosis, and lung nodules. Which one is causing the other? The exposure to the coal will cause rheumatoid arthritis or rheumatoid arthritis? No. Kaplan syndrome is this. It happened that the patient has rheumatoid arthritis. He is a rheumatoid arthritis patient. But it happened that he's working in coal atmosphere. So he got two problems in his lungs. He has the pulmonary nodules from rheumatoid arthritis, and he has pulmonary nodules from coal worker pneumoconiosis. That's why if you look at the X-ray of this patient, it's going to be with a lot of nodules. Some of them are big, some of them are small, some of them are due to the rheumatoid arthritis, some of them due to the coal exposure. Okay? So that's Kaplan syndrome. It is the patient who has rheumatoid arthritis and exposed to this dust in his occupation. Borreliosis. When you see this, I want you to remember sarcoidosis, and you need to differentiate between both of them. Why? Because if you get an X-ray, you will see the same, almost the same on the X-ray. How do you differentiate in your practice or in the exam? With the history. If they tell you that the patient has been exposed to or working in electronics or aerospace or fluorescent bulb, something like that, that's borreliosis. And the X-ray is going to be almost the same. Look at this, sarcoid-like granulomatous reaction. Upper zone with hilar lymphadenopathy. Sarcoidosis might present at this, but it's idiopathic. It's like it's not associated with occupational kind of dust exposure. So the borreliosis history is important. Cell-mediated immune response that can happen, and it's going to persist even after short time of exposure to the beryllium. The diagnosis, by the way, they might try to push you to say check the level of beryllium in the blood. That's not the way. The way is a specific test. We call it beryllium lymphocyte transformation test. That's the way to diagnose borreliosis. And remember that steroids are effective in treatment of the symptoms of these patients. I mentioned that the only organic dust is the cotton dust, causing what we call it bicyanosis. The hint is going to be, they have to tell you that the patient is working in a factory, exposed to flux dust, or in a cotton factory or something like that. And the symptoms usually severe and starts after the weekend. I mean, after 3-4 hours from starting the work on Monday, early in the working days, because the patient is going to start to have the exposure, severe exposure, and he's going to get significant tightness, shortness of breath, and dyspnea, and all these things. And basically, you have to avoid this. And the treatment is exactly like COPD, which is symptomatic. But the real treatment is to take the patient away from this atmosphere. Question. 67-year-old retired naval shipyard worker presents with complaint of increasing dyspnea. He never smoked in his life. His X-ray reveals pleural plaques along the diaphragmatic border bilaterally. Which of the following is least likely to be true regarding his disease? Can you tell me what is his disease? What do you call this disease? You call it asbestos or asbestosis or mesothelioma or asbestos exposure? I'm going to tell you, and you need to differentiate between all of them. So there is something related to asbestos here. So which of the following is the least likely to be true regarding his disease? Meaning 1 out of these 4 choices is wrong. Increased risk of mesothelioma, is this true or wrong? Exposure to asbestos, is it increase the risk of mesothelioma? For sure. There is an increased incidence of small cell and lung cell carcinoma, increased risk of lung cancer in patients with mesothelioma. Lung cancer, yes. Pleural disease may manifest as massive effusion. Yes. Parietal pleural plaques are usually found from the 6 to 9 ribs and tend to spare the apex and the costophrenic angle. Yes, that's right. So all of them are right. Which one is wrong? Did I put the question in the wrong way? Or let me tell you, the exposure to asbestos will increase the risk of lung cancer, but not small or large cell carcinoma, squamous and adeno. Okay, and mesothelioma for sure, which is not lung cancer; it is pleural cancer. Okay, so that's the asbestos exposure. So asbestos exposure will increase the risk of squamous and adenocarcinoma of the lung. Here is I want to tell you about this because you will see this in your practice a lot. The word asbestosis means pulmonary fibrosis concentrated at the base of the lung, and this is where the fibers will settle. So the fibers of the asbestos are heavy, and it's going to settle down to the base of the lungs. And we usually stain it with Prussian blue because we have iron coating the asbestos fibers. So this is one of my patients with the very obvious on the pathology slide or histopathology that the patient has asbestos down here. Let me tell you about this because you will have patients coming and tell you, please tell me that I have asbestosis. Okay? Report that I have asbestosis. I was working. When are you going to put in your report asbestosis? Only if you have this X-ray documenting that the patient has asbestos exposure. So the patient has asbestos exposure with fibrosis. However, if the patient doesn't have this fibrosis in the base of the lungs, he might have what we call it asbestos-related pleural disease. Or the patient might have documented exposure to asbestos, but you get an X-ray and pulmonary function test and everything is normal. What are you going to put in your diagnosis? History of asbestos exposure, not asbestosis. So asbestosis, because you will be responsible for this, most probably is going to be something you will go to the court for it because the patient is going to ask for compensation and all these things. So to say asbestosis, you have to have lung with significant fibrosis in the bases of the lungs and restrictive lung disease on pulmonary function test. Okay, that's asbestosis. If the patient has everything normal, but he has documentation that he's exposed to asbestos, you can say history of asbestos exposure. That's it. That's your diagnosis. However, the third situation is this. The patient might have pleural plaques, pleural effusion, or mesothelioma. That's what we call it asbestos-related pleural disease. So if the patient has something like the pleural plaques, which is usually in the mid-thoracic area, like 5, 6, 7, 8, but not in the diaphragmatic area or in the apex, that's usually what we call it asbestos-related pleural disease or pleural plaque. And it is not asbestosis, as I mentioned before. So meaning that the patient might have problem in the pleura, but he doesn't have anything in the lungs. So you cannot call it asbestosis. You call it asbestos-related pleural plaques. And it is benign. The other condition is that's one of my patients who has both. Actually has asbestosis and he has the pleural plaques, which is in the mid-thoracic area and in the diaphragmatic area as well. So your diagnosis here, asbestosis, with history of exposure to asbestos and pleural plaques as well. But this is benign. Okay. The other condition is what we call it pleural effusion related to the asbestos exposure. So benign asbestos related pleural effusion, which sometimes be hemorrhagic, but it's still benign. And that seen after exposure more than 5 years for the asbestos. So now we have different kinds of diagnosis for the asbestos exposure. The third one, which is the, this is actually hemorrhagic pleural effusion, and it is still benign. You have significant effusion, and it's hemorrhagic, but it's benign. The asbestos-related pleural disease with mesothelioma, that's the malignancy of the pleural fluid, pleural cells, and it's pathognomonic for asbestos exposure. If you have a patient with mesothelioma, it means that he has exposure to asbestos, no doubt about it. However, the incidence is unaffected by smoking. Why I put this here? Because this is a question on the exam. They will tell you the patient has history of exposure to asbestos, and he is a smoker. Do you think that the smoking is going to increase the risk for mesothelioma? The answer is no. The smoking will increase the risk for lung cancer, not pleural cancer, not mesothelioma. The only factor that will increase the risk of mesothelioma is asbestos exposure. Okay? However, if the patient has history of asbestos exposure and is a smoker, that will increase the risk of lung cancer significantly more than just smoking. Okay? So meaning asbestos will increase the risk of lung cancer as well, but smoking will not going to increase the risk of mesothelioma. And can be seen in the pleura or in the peritoneal cavity as well. Now we don't have a specific treatment. We have a lot of trials. Mortality is very high. We diagnosed the patient, I think 3-4 years ago, and he died within 6-8 months after the diagnosis with the mesothelioma. So this is the, look at this. This is the mesothelioma and causing malignant effusion at this time, and the mortality is very high. All of the following are true regarding malignant mesothelioma except latent period is usually 30 years after exposure to asbestos. 5% of asbestosis workers will die from mesothelioma. There is no relationship to cigarette smoking. Patient with suspected pleural mesothelioma require fine needle biopsy to obtain cells for definitive diagnosis. The median survival is 6 to 12 months Which one is wrong? So how are you going to get the diagnosis? Definitive diagnosis. You are right. C is wrong. And what I want you to remember, if you put a needle, the malignant cell is going to track. It's gonna spread through the needle track where you put the needle for the needle biopsy. So open pleural biopsy for mesothelioma. You guys remember when I talked about TB? I told you open pleural biopsy to culture the pleura for TB. Okay. Never, if you suspect mesothelioma, never put a needle to the chest of the patient. Send the patient for open pleural biopsy to get a specimen and send it for the pathology. I have seen one case. This was in Detroit. This hospital is not existing anymore. That was like a long time ago. And the patient came to the ER, and he has massive pleural effusion and needle inserted, and he came like maybe 3 months or less than 3 months with significant malignant infiltration of the chest wall with the malignant cells. So avoid this. What is the other condition that you need to avoid needle biopsy? Which kind of malignancy? I'm going to give you a hint. It is only in males. Ovarian cancer? Oh, no, I mean, that's off the list. Okay, that's number one. So testicular cancer. If you suspect testicular cancer, never put a needle to get a biopsy, because the malignant cell is going to track this to the scrotum, and the lymphatic drainage of the scrotum is different from the lymphatic drainage of the testicles. So para-aortic lymph nodes for the testicles, the superficial inguinal for the scrotum. So if you do this, you will meet the family in the court, 100%. I don't think that any surgeon is going to do this. They will never. You know how to diagnose this? Yeah.
Just a technical question after this. Let's say, example, you have a person that you don't know has mesothelioma or some level of asbestos exposure. That's not. So my point then is, if let's say they have a malignant pleural effusion, which you think you don't know what it
exactly
caused,
right.
You put a needle to a thoracentesis.
Right.
Would they technically be able to sue you?
See, you have to be careful in your. I'm telling you about the practice, but on the exam they will give you very, very obvious hint that the patient has exposure to the asbestos, and they will give you this, and they might give you even the classic appearance with the pyramidal shape. That's for the exam. But for your practice, if you have this, like you know that the patient has history of exposure to asbestos, and he has pleural effusion, I will not going to do the thoracentesis. I'm going to send the patient for surgery, because who knows if this is lung cancer or mesothelioma. Okay? That's for your practice. Keep this in mind. You don't want to get to this problem and the patient is going to come later and say, he's going to die from mesothelioma, but the family will stand and will say, hey, you spread the disease to his chest wall, and you know what I mean? So be careful with this. Just keep it in your mind. But for the exam, it's going to be very obvious that they give you, oh, are you going to put a needle? No, I'm not going to put the needle. Okay? The testicular cancer, if you suspect this, most probably with the ultrasound when you send the patient, or usually young male, and the radiologist is going to tell you most probably this is something like seminoma or whatever, or suspected malignancy. What are you going to do? Well, we don't put the needle. What we have to do is to open the inguinal area, pull the testicles with the epididymis and the spermatic cord all together and snap it and send it to the pathology. But don't put the needle. I have done this several times, actually. You have to do the whole area. You pull it and you send it. And that's part of the treatment because that's what you need to do for the treatment of testicular cancer. Okay? So this is two things that I just want you to remember. We ask about it on the exam several times. Although we are not the person who will do either one, but you have to know the consequences. So squamous and adenocarcinoma, as I mentioned before, associated with asbestos exposure. Hypersensitivity pneumonitis, this is the last one in the occupational lung disease causing restrictive lung disease. It is basically occupational history. That's because the lung is going to be X-ray with non-specific kind of interstitial kind of marking. So the hint on the exam is going to be like moldy hay or thermophilic actinomycetes, which we call it farmer's lung, grain dust exposure, pet birds, air conditions, and even cocaine exposure can cause hypersensitivity pneumonitis. Bird fancier disease or bird droopings can cause the same condition. So look at the history of recurrent ER visit with suspected pneumonia in non-smoker, and the treatment is not helpful. When you give just the antibiotic, it will not going to help. So the issue is to avoid exposure to the offending agent. That's the best way. Serum presbytins are non-specific because it's going to tell you the patient has exposure but not acute episode. And remember that patients with hypersensitivity pneumonitis will not going to have eosinophilia, and that's going to help you to distinguish from eosinophilic pneumonia that I'm going to talk about it. But the eosinophil will not going to be high. Immunoglobulin E will be normal in patient with hypersensitivity pneumonitis because it's not type 1, it is type 3 and type 4 hypersensitivity. So it has nothing to do with immunoglobulin E. Okay? I'm going to talk about this down the road, eosinophil and immunoglobulin E. How do you treat? Eliminate exposure to a causative factor. That's the treatment of hypersensitivity pneumonitis. The other thing is what we call it the hot tub lung disease, Mycobacterium avium complex. You remember when we talked about infectious disease, I mentioned this when we talked about Mycobacterium avium complex. You should treat the patient with 4 antituberculous medications for 9 months if the patient has hot tub lung symptoms. Is this true or false? You are right. This is false. No, because this is not an infection, an invasion of the lung with this microorganism. It's hypersensitivity to this microorganism causing the symptoms of what we call it hot tub lung symptoms, which it's like some sort of wheezing and difficulty in breathing. So corticosteroids and discontinue hot tub use, and it is hypersensitivity to the organism and not invasion of the lung with these organisms. So advise the patient to sell his hot tub. That's not a good idea to continue to use it. Okay. Remember that acute bronchopulmonary aspergillosis has both eosinophilia and immunoglobulin E will be high, and I'm going to talk about it. Acute bronchopulmonary aspergillosis, I think we talked about this in infectious disease as well, which is the patient will have eosinophilia and high immunoglobulin E. And the treatment here, the main point of the treatment again is steroids.